In closing, ophthalmology strongly believes that compounded drugs must be produced safely and be subject to critically important testing. We do believe that regulatory policy in this arena can become restrictive and in turn negatively impact physicians' ability to properly and effectively treat patients. It is important that as implementation efforts move forward, the FDA strives to find more balanced approach.
And you don't need a big batch, you just need a couple of small batches. Isn't that correct, from time to time?
I just need enough to have on the shelf so when that one patient a week comes in, I can take care of them.
And I worry about my rural areas and my folks who are, have a problem suddenly, an emergency late at night or on the weekend, and there is no compounding pharmacy readily available in that small rural community. Is that a concern for your doctors as well?
Absolutely. That's one of the most common scenarios that we hear. For the incidents where timely treatment is critical, and as I mentioned earlier, infections of the eye, even a delay of an hour or two will have adverse effects. So we need to be able to have these drugs available in office. We can just pull them off the shelf, and it's just absolutely critical. I alluded earlier to the pool cleaner for this type of infection, and it sounds crazy that we would use a pool cleaner for an infection in the eye, but I can assure you, if you had that infection, you would want immediate access to that treatment. There are many ophthalmic drugs that are available through 503Bs, and we encourage our members to use those. But it's these relatively rare conditions, but yet very potentially catastrophic, where we need immediate access, and simply writing a prescription and then having the patient have to go get it, if in fact they can get it. These are drugs that are not typically manufactured or compounded at a high rate. So for a rural population, it could be literally hundreds of miles